Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello everyone, I'm Paolo Tarantino from the Dana-Farber Cancer Institute. So happy to join this program, this Medscape program called Charting New Frontiers in Advanced Breast Cancer, Milestones, Missions and Mastery. We're going to try with an amazing faculty that I'm about to present to discuss what happened last year in terms of developments for advanced breast cancer, and a lot has happened, little spoiler, and we'll try to also dive deep into some of the challenges and open questions in the field. To do this, I'm very lucky to be joined by two amazing faculty. We have Kevin Kalinske, Professor Director of Medical Oncology at Emory in Atlanta, and Sibyl Loibs, Professor of Innovative Therapy in Breast Cancer in Frankfurt, and also CEO of the GBG Group in Germany. Thank you so much, Kevin and Sibyl, for joining this program.
Thanks, Paolo.
All right. So let's jump into the agenda. And what we will try to do is go through the milestones of 2025, what has happened in each major subtype of advanced breast cancer, and then review the missions. So what are the remaining challenges in the fields of treating metastatic and advanced breast cancer? Finally, go deeper into some clinical cases to see how the recent developments may be applied in clinical practice. And finally, we will have some time for question and answer and live discussion within the faculty. But before that, I would like to basically explain that really there was so much happening in each of the subtypes, so many classes of agents. We will start from ER-positive disease, where so much has happened. And so, Kevin, please take us through what has happened in 2025 for HR-positive, HER2-negative breast cancer.
Thank you, Dr. Tarantino. As Paolo had mentioned, a lot has happened with this subtype of breast cancer, and we won't have time to go through all of the data and all of the studies, but we opted to highlight some specific studies. So we'll be talking about Anavo-120, Serena-6, Ember-3, Avera, as well as Victoria-1. Some of these are approved. Some of these are not yet approved approaches, but we anticipate will be hopefully sometime in the next year or so. So the first study, just to mention, is Anavo-120. This is a trial for a very specific patient population of patients who have tumors that had progressed during or within 12 months of adjuvant endocrine therapy completion. And this is also for patients who had PIK3CA mutations. And this was a trial where patients were randomly assigned to receive fulvestrant plus palbociclib versus fulvestrant, palbociclib, and inavolisib. It was a placebo-controlled trial. You can see, again, this was a frontline study, and there were some glucose parameters in order to be eligible, and the primary endpoint was investigator-assessed progression-free survival, which we had previously seen and were reported in the New England Journal of Medicine. And then more recently, we saw the data in terms of overall survival. And so we see a benefit now, an absolute delta of about 7 months, with the triplet arm being 34 months median overall survival. And this is the first time that we've really seen with an agent that has targeted this pathway an improvement in overall survival. So what are some of the side effects similar to what we see with other agents that target the pathway? We can see hyperglycemia in the novelisib arm. You can see the grade 3-4 events were a little shy of 7%. There's also some diarrhea, rash, though those were tended to be lower grade. But the one thing to really keep in mind is the risk for stomatitis. And when I have treated patients on this regimen, I've considered utilizing even prophylactic steroid rinse if it's available in your country to help prevent that side effect. So moving along to Serena 6. So this is a study, again, this is frontline hormone receptor positive HER2 negative disease. These are patients who had been on an aromatase inhibitor and CDK4/6 inhibitor in the front line for at least 6 months. And then patients started to have screening with for ESR1 mutations. So patients, if they were identified of having ESR1 mutations, were randomly assigned to receive camizestrant plus continuing the CDK4/6 inhibitor versus continuing said aromatase inhibitor plus CDK4/6 inhibitor. And this was also placebo controlled. The primary endpoint was progression-free survival. What we saw was that there was an improvement in progression-free survival. This replicates data that we had seen from another study, PADA-1, which utilized fulvestrant as the SERD. And then we've also seen some data, updated data in terms of progression PFS2. And so just to make sure we're all on the same page, the way that PFS2 was defined in this study is that patients from the time of randomization through that first progression and then onto the subsequent line, what was that total duration of time? And you can see that PFS2 also favored the CAMI arm. One of the compelling bit of data that were presented at ESMO last year and also published in Annals of Oncology was just reports on how patients felt. And you can see whether it was physical functioning or emotional functioning. We'd already seen prior data in terms of pain, that there was an improvement in the patient-reported outcomes as well. So in terms of the safety, the main side effect that was seen was neutropenia, which was really what was being driven by the CDK4/6 inhibitor. One unique aspect of camizestrant compared to some of the other oral SERDs is photopsia, and how this has been explained is it's almost similar if you're leaving a theater and then you're walking outside and you have that moment where your eyes are adjusting. That is noted with camizestrant, though the rates of anything beyond low grade, the majority of these were low grade photopsia. Moving along to EMBER-3. So this was a study that had previously been presented, though we saw some updates this year. Imlunestrant has been approved for patients with ESR1 mutations, and then more recently in NCCN guidelines, it is included in the guidelines of imlunestrant plus abemaciclib. That's an update from it's been about 3 to 4 weeks or so. So in EMBER-3, patients could either have received adjuvant therapy and then recurred on or within 12 months of completion of that aromatase inhibitor without CDK4/6 inhibitor, or they had tumors that had progressed on frontline therapy. It is worth mentioning not all the patients in the study had received a prior CDK4/6 inhibitor. And so it's a 3-arm study, imlunestrant versus physician choice endocrine therapy, and there was also an arm of doublet therapy of imlunestrant plus abemaciclib, though that was started a little bit later, which is why you see that's in the schema a little bit shifted to the right. Primary endpoints were progression-free survival. They looked in patients with ESR1 mutations as well as all patients as well. So these are the updated data that are looking at Imlu versus physician choice endocrine therapy. This is for patients with ESR1 mutations. I had mentioned it, but just to reiterate, this approval as single agent is exclusively in those with mutations. And we saw that the PFS difference was around 2 months or so. But we also see in terms of overall survival data that there is this improvement of survival with imlunestrant with a difference of almost 10 months or so. We also have seen updated data in terms of the combinations. In this analysis, again, this is looking at Imlu alone versus imlunestrant plus abemaciclib. The median progression-free survival of the doublet was a little shy of 11 months. And, one of the things about the doublet is that as opposed to what we're seeing with single agent imlunestrant, that with the doublet, it's regardless of the presence or absence of ESR1 mutations. When looking at overall survival, the hazard ratio is 0.82. We'll look for some additional follow-up here. For imlu alone, you can see the median overall survival was 34 months, and it's not reached yet with the combination. In terms of side effects that we can see with imlunestrant, these tend to be things like gastrointestinal issues. I just want to call out, if you look at imlu alone, that the rate, any grade rate of diarrhea is a little shy of a quarter of patients. There can also be some nausea, some fatigue that is reported. And then this will come to no surprise, but when you add on abemaciclib, that rate of having diarrhea and nausea increases. And then also risk of the hematologic toxicity as well due to the abemaciclib. So moving along to Avera. So Avera was reported also at ESMO last year. So this is a study in patients who received up to 2 prior lines of endocrine therapy in the advanced setting, had tumors that had progressed on CDK4/6 inhibition, no prior chemotherapy. Patients were randomly assigned to the oral SERD giredestrant plus everolimus versus standard of care endocrine therapy plus everolimus, and there were a little shy of 400 patients that were enrolled to this study. These are the data for patients with ESR1 mutations where the majority, if not all, of the benefit was seen, where you can see that the combination of giredestrant plus everolimus had a median progression-free survival of 10 months. Again, this is for patients with ESR1 mutations, as opposed to standard of care endocrine therapy and everolimus, which is a little bit more than 5 months. You see a hazard ratio of 0.38, which is quite impressive. This is looking at the ITT population, again, the hazard ratio being 0.56. But as I mentioned in an exploratory analysis, the patients who were ESR1 wild type really did not have the benefit that was seen as those with ESR1 mutations. With giredestrant and everolimus, the main toxicity that was seen was stomatitis. You can see that in the control arm as well. This is really due to the everolimus. Those rates don't seem to be much different with the giredestrant. Other things that are seen included some hematologic toxicities, and then other ones that are listed here, such as diarrhea and fatigue. And then moving along to Victoria 1. So this also was presented at ESMO. There are 2 different studies. There's one which looks at patients with PIK3CA mutations, which has not been presented yet. But what was presented was in the PIK3CA wild type population. And so this is quite interesting because gedatolisib is an intravenous agent that also targets mTOR, mTORC1 and mTORC2. This was a study that was a 3-arm study. All these patients had progression on or after CDK4/6 inhibitor and an aromatase inhibitor, no more than 2 prior lines of endocrine therapy for advanced disease, similar to what we just talked about with the Avera study. There was also no prior chemotherapy, similar to what we just talked about with the Avera study. And these patients had no prior access to mTOR or PI3K or AKT inhibition, just given that this agent targets mTOR and PI3K. In this study, there's the triplet of geda plus palbo plus fulvestrant. Arm B is doublet, and then arm C was fulvestrant alone, and there was crossover that was allowed. And the primary endpoint was looking at blind independent central review with PFS. So these are the data with the doublet. So again, comparing fulvestrant to fulvestrant plus geda, and you can see a hazard ratio of 0.33, and the doublet led to median progression-free survival of 7.4 months, and the fulvestrant arm behaved with what we commonly see in other studies of around 2 months or so. And then we see data with the triplet compared to fulvestrant, where there was a little bit more of a magnitude of benefit with a hazard ratio of 0.24 and a median progression-free survival of around 9 months with the triplet. In terms of side effects that we see, stomatitis, there's a risk for rash, also some diarrhea and hyperglycemia. And I'm just going to go back for a minute because I can't remember if I had actually said this, but the geda is given intravenously, but I don't know that I had mentioned that it is given 3 weeks on, 1 week off. Okay. And so right now we do not have giredestrant based upon Avera approved. We also don't have the approval for geda yet based upon the Victoria 1 study. And then just to shift for a moment and talk about the context of endocrine resistance, we did see at San Antonio data from Ascent-01. So this was looking at a population of patients who've had tumors that had previously progressed on endocrine therapy and had not had any prior chemotherapy or ADC. So this was from the time that patients had completed their endocrine therapy, had endocrine resistant tumors, and then were shifting to receiving something like an ADC or chemo. And in this study, patients received sacituzumab govitecan, the TROP2 ADC, which is given 2 weeks on, 1 week off, versus physician choice chemotherapy. It was a 2-to-1 randomization with 690 patients, and the primary endpoint was PFS, again by BICR. One of the surprising things that was seen with the study, and this is different than what we've seen with other ADC studies that are looking at agents early on, such as what we've seen with TDXD. In this particular study, this was a negative study. We did not see an improvement in progression-free survival. You can see in both arms that was 8.3 months. I will say, just before we move on to Dr. Loibel talking about HER2-positive disease, there was a trend towards some improvement with overall survival in ASCENT 07, but of course we need additional follow-up as the primary endpoint was negative. I will now pass this along to Dr. Loibel.
Thank you, Kevin, and good evening, everybody, or good afternoon, wherever you are in the world, maybe also good morning. I will be speaking about the HER2-positive breast cancer, and I think overall the HER2-positive breast cancer in the last 20 years is really a success story, and we are very close to cure this disease. So I will be speaking first about the Destiny Breast 09 study. I will have the HER2CLIMB 05 study, and then I will be bringing with you, of course, the PATINA study. So 3 studies overall. The Destiny Breast 09 study is a 3-arm trial investigating the role of the TDXD in first-line HER2-positive metastatic breast cancer. So the standard of care based on the Cleopatra trial is a taxane plus HP, trastuzumab plus pertuzumab, and this is compared to either TDXD alone or TDXD in combination with pertuzumab. And so far, we have only the results of the 2 arms here in the middle, the TDXD plus P versus the Cleopatra regimen, as the other arm has not yet matured. It's a straightforward metastatic breast cancer trial with the primary endpoint of PFS, and we can enroll patients who have not yet received any treatment for metastatic breast cancer, and they had to have a disease-free interval of more than 6 months from the last chemo or HER2-targeted agent for their primary cancer. We stratified the patients by de novo versus recurrent disease, by the hormone receptor status, and by the PI3 kinase mutation status. So this is the primary endpoint, the PFS by central review, and you can see here statistically significant and also a clinically meaningful improvement of the progression-free survival when TDXD was combined with pertuzumab compared with the Cleopatra design, which was the standard of care for a very long time, and with a hazard ratio 0.56. The PFS in the TDXD plus P arm was over 40 months versus 27 months in the THP arm. And this is actually longer compared to what we have seen in the Cleopatra trial, but it's a slightly different setup. And the majority of patients, 40% of the patients, were still under treatment when this interim analysis read out. This has to be borne in mind. Response rate was also great, and you can see a very high overall response and response rate with a 15% complete response and 70% partial remission compared to THP. The partial remission is exactly the same, but what really makes the difference and drives the difference is the rate of complete response rate, which is about almost double what we have seen with the Cleopatra regimen. There is no difference regarding the effect size of TDXD plus pertuzumab regarding by the hormone receptor status. We had an extended analysis of the subgroup by ESMO last year, and you see on the left side the hormone receptor positive group, which tend to be a little bit better behaving than in general than the hormone receptor negative subgroup, but both groups benefit to the same extent from TDXD plus P. And then, of course, no new treatment, and you're already very familiar, I guess, with the treatment of TDXD in general, and TDXD plus P has an additional diarrhea rate. We know pertuzumab adds to the diarrhea. We have nausea, neutropenia, but all other side effects are well known. Alopecia is about the same in the two treatment arms, and peripheral sensory neuropathy is higher as expected in the Cleopatra regimen due to the taxanes given here, but otherwise no unexpected side effects based on this study. So this is the HER2CLIMB-05 study. What is the novelty here? It's the question of maintenance treatment, and the Patina trial answered the same question. So do we really need to give the chemotherapy as long as needed and just then stop it and just continue with HP, or can we do better while increasing or improving on the maintenance treatment? And the HER2CLIMB study added, after finishing the THP, the chemotherapy part, after 4 to 8 cycles, to add tucatinib to HP, or just continue as per standard of care with HP. And this was a placebo-controlled trial with a 1-to-1 randomization. And again, primary endpoint was, at this time, the investigator assessed progression-free survival. And this is again first line, and we can see here with a hazard ratio of 0.64 an improvement of the progression-free survival, but using an, I would call it an improved maintenance concept with a triple anti-HER2 agents, trastuzumab, pertuzumab, and the addition of tucatinib. We have seen here in the control arm 16 months versus 25 months in this overall cohort. The overall survival, there is a strong trend, improving also the overall survival with 18 with 33 events, but this is not yet mature. We have seen data at the last big meeting in San Antonio with the CNS PFS, because we have seen the first HER2CLIMB data specifically was powered to look into the patients with CNS metastasis. And we have here the overall population on the left side, where there is no difference, and on the right side, we again see a separation of the curves, smaller events, smaller number of patients. That's why it's not statistically significant, with a delta of about 4 months in favor of the tucatinib maintenance treatment, also for patients with baseline brain metastases. Safety, again, nothing really unexpected. We know that tucatinib adds also to the diarrhea as a HER2 targeted, pan-HER2 targeted TKI. We have seen here a diarrhea rate of 73% overall, with grade 1 and 2 about 2/3, compared to 50%, and the grade 1 and 2 to just about 47%. Then we have nausea, vomiting, liver enzyme elevation in the tucatinib arm, and others were not different between the two treatment arms, to nominate here the most important side effects. The Patina study was slightly different, because here it was looked just exclusively into the hormone receptor positive subpopulation, where the patients after 6 to 8 cycles, so a little bit longer chemotherapy regimen, either taxane plus trastuzumab or taxane plus trastuzumab pertuzumab, was eligible, and the patients had to have, of course, a stable disease or at the minimum of response, and then they were randomized to continue the maintenance treatment with HP or trastuzumab, depending on what the patient have received before, plus endocrine therapy. And this is also already a novelty, because this was not done in the Cleopatra trial. We were not used to continue with an endocrine agent, so endocrine therapy based in both arms, but in the experimental arm, palbociclib was added on top as a CDK4/6 inhibitor. And going back to the very first cell line data, we saw an improvement in the response, also in the HER2 positive subpopulation, and this concept has been taken up here on the maintenance treatment. And since this is a hormone receptor positive subpopulation, we had to wait for a long time, and the primary PFS analysis is shown here. 29-month progression-free survival in the control arm compared to 44 months in the experimental arm with the CDK4/6 inhibitor on top of endocrine and the targeted agent against HER2 treatment. So the cumulative incidence of this CNS progression or death were also evaluated and showed that there is also an improvement in the group which received the CDK4/6 inhibitors for the CNS incidence. So that's why we have the reverse Kaplan-Meier curves here. The green line is below the blue line here, and we have a lower incidence in all at 1 year, at 2 years, and at 3 years. We have 14% versus 20% of progressions or death due to CNS metastasis. And this also shows that we still have a problem with this high rate of CNS mets and progressions. Safety, we have anti-HER2 treatment, we have the dual blockading, we have the CDK4/6 inhibitor, and of course we have a higher rate of neutropenia due to palbociclib, which is the main toxicity here in this study. Diarrhea rate is also higher in the control in the experimental arm, fatigue a little bit higher, and we see a little less arthralgia. We know that already from other studies that the CDK4/6 inhibitors seem to reduce the arthralgia rate a little bit, and otherwise nausea a little bit higher, headache higher, but the majority based on the addition of palbociclib as another quadruple agent on top of HP or trastuzumab plus endocrine therapy. You have seen that the data are now published in the New England Journal of Medicine. And if you want to really drill down, both trials I have presented you, the TDXD plus BDB09 and the PATINA study, have recently been published in the New England Journal. So go back and read yourself what has been the novelty of the last year. Thank you.
Thank you, Sibyl. Thank you, Kevin, for this amazing overview of a lot of stuff happening in HR positive and HER2 positive disease. And I think even just with these developments, it would have been a tremendous 2025, which changed so much. But in truth, we also see some advancement in the treatment of probably the hardest to treat subtype of metastatic breast cancer, that is triple negative breast cancer. And so let's dive into it. What happened basically is that there were several trials of first-line ADC compared with chemotherapy that were presented and published over the last year. And the first one was ASCENT-04. This is a trial dedicated to patients with PD-L1 positive metastatic triple negative breast cancer that had not received yet any treatment for metastatic disease. So first-line setting, PD-L1 positive, patients were randomized to the standard first line, that is chemotherapy, either taxane-based or platinum-based with pembrolizumab, or sacituzumab govitecan pembrolizumab. And we know that SG is already approved in later lines, and here the idea was bringing it to the first line, with the primary endpoint being progression-free survival by BICR. And basically, when you look at the results, the primary endpoint was met. There was a significant improvement in PFS with SG Pembro compared to chemo Pembro, 11.2 months with SG Pembro compared to 7.8, as a ratio 0.65, basically a reduction of about 1/3 in the risk of progression or death, which was quite remarkable in this population of patients. You can see that overall survival in truth was very similar in the two arms, but there's also a reason for that, because this trial had built-in crossover, and so all patients that progressed on the control arm had potential access to sacituzumab govitecan offered by the study. And so that can, of course, mix up overall survival results, and which is why the primary endpoint was only progression-free survival in this trial. In terms of side effect profile, we know SG quite well. Here there weren't unexpected toxicities. We know that SG is associated with relatively high rates of neutropenia, fatigue, alopecia, and diarrhea. But once again, no surprises in this trial. And also with chemo Pembro, no surprises. Of course, a bit more peripheral neuropathy in the chemo Pembro arm because of the taxanes, much less with SG Pembro. And so a sibling trial was ASCENT-03, also a phase 3 trial, also for patients with metastatic triple negative breast cancer in the first line, but this was restricted to patients either with PD-L1 negative tumors, which are the majority, about 60 to 70% of the cases, or PD-L1 positive previously treated with immunotherapy or ineligible to immunotherapy. So here, for patients with first-line metastatic triple-negative disease that cannot receive immunotherapy, the comparison was sacituzumab govitecan versus standard chemotherapy, either a taxane or carboplatin gemcitabine, similar to ASCENT-04. Primary endpoint progression-free survival, once again, built-in crossover. Patients could receive SG after progression on the control arm. Positive trial, improvement in PFS, 9.7 months with SG compared to 6.9 months with chemotherapy, as a ratio 0.62, very consistent with ASCENT-04, suggesting that in terms of PFS, there is an improvement with SG compared to chemo, similar to what was observed also in the ASCENT trial in pretreated patients. Also here, no difference in overall survival, likely related to the crossover. Response rate also was quite similar, 48% with SG versus 46% with chemo, but durational response was actually longer with SG. And probably that's related to the fact that there are less limiting toxicities with SG, duration limiting toxicity. So taxanes, most patients have to discontinue them after a while because of neuropathy. You don't have this with SG, so prolonged durational response. And in terms of side effects, similar side effect profile compared to what observed in previously in ASCENT, neutropenia, diarrhea. In terms of serious adverse event, a slight increase in the SG arm, and there were 6 the drug-related grade 5 events, fatal side effects, mostly related to sepsis in patients that should have been eligible for growth factor support but did not receive it in the trial, which is just a reminder of how important it is to monitor, but also to utilize prophylactic growth factors in patients that are either, let's say, elderly patients or frail patients or patients that should receive, in general, prophylactic growth factors with SG. And here also you have more in detail the side effect profile. Once again, neutropenia, about half of the patients have grade 3 or higher, important to remember. Nausea, alopecia, and diarrhea really are the key toxicities with this agent. And finally, the third trial that also showed a benefit in the first line for triple-negative disease is TROPION-Breast02. This was also a trial for patients with metastatic triple-negative breast cancer that had never received treatment in the first-line setting. So first-line trial, patients either were generally not eligible for immunotherapy, so either PD-L1 negative or PD-L1 positive, but without an option to receive immunotherapy. And they were randomized from between Dato-DXd or physician choice of chemotherapy, of single agent chemotherapy. That could be a taxane or capecitabine, eribulin, or carboplatin. Here we had a dual primary endpoint, both progression-free survival and overall survival, especially because this drug was not previously approved for triple-negative disease. And what was observed is that there was indeed a benefit in progression-free survival. You can see that the curves diverged pretty early, 10.8 months as a median with Dato-DXd compared to 5.6 with chemo, as a ratio of 0.57. And in this case, there also was a benefit in terms of overall survival. And you can see the hazard ratio of 0.79 and the median of nearly 2 years with Dato-DXd compares of about 1.5 years with chemotherapy. And of course, in this trial, there was no built-in crossover to Dato-DXd, but about 30% of the patients did receive some form of ADC after discontinuing on the control arm. That could be T-DXd or SG. So some indirect crossover did happen here, but still there was an overall survival benefit. Response rate was basically doubled with Dato-DXd, about 30% with chemo compared to 62% with Dato-DXd. Durational response was also improved with Dato-DXd. And in terms of side effect profile, although Dato-DXd, similar to SG, is a TROP2 targeted ADC, the side effect profile is a bit different. And we see that often this is related to the structure of the ADC, the linker, the amount of payload, and all that. And so in this case, we mostly see actually mucosal surface toxicity, including dry eye, stomatitis, in general, ocular toxicity. Nausea is also observed, but much less neutropenia, anemia, and leukopenia. So hematologic toxicity is not a concern, usually with Dato-DXd, but you do see, once again, mucosal surface toxicity and alopecia as well. And there was one patient with a fatal ILD, which reminds us that still you can see, just like with T-DXd, also with Dato-DXd, some risk of interstitial lung disease, which warrants careful monitoring of the lungs during treatment. All right, after this marathon going through the developments in 2025, so many developments, still there's so much to do. And these are the missions. I highlighted a few missions here, most related to ADCs, just because really they're becoming a treatment modality for all breast cancer subtypes. But I think some of these challenges apply also to other drugs, such as oral SERDs. And one issue that pertains both ADCs and SERDs is sequencing. Now that we're starting to have so many agents with potentially overlapping indication, how do we sequence them? And for instance, with ADCs, you can see that both in HR-positive, HER2-negative disease or triple-negative disease, potentially we can sequence 3 different ADCs, TDXD, Dato-DXd, SG, based on the trial enrollment criteria. Potentially a patient may receive the 3 of them in sequence. But the question is, should the patient receive this in sequence? And the truth is that we don't have any answers because there is no prospective trial that has asked this question yet. We have some retrospective data which suggests that there is some cross-resistance between ADCs. We published last year this work in Flatiron looking at the outcome of different treatment modalities immediately after TDXD. And so using SG after TDXD did seem to have a relatively shorter progression-free survival compared, for instance, to a taxane or capecitabine or eribulin in HR-positive disease, whereas in triple-negative disease, with a smaller cohort, not much difference. And so it really remains an open question, which is why we really need additional data. Some data, although in HER2-positive disease, we will present it at ESMO Breast, basically in a few weeks from now. So there is a plug. Join us in Berlin, and I'll get to present the SATIN trial, which was a trial that tested SG trastuzumab after TDXD for HER2-positive breast cancer. But we also have a larger ongoing trial called TRADE-DXD, looking at the sequence of TDXD after Dato-DXD or the opposite, and this is ongoing, and also we hope it will provide some answers to this sequencing question. Second major question, we reviewed the side effect profile in all of the trials across subtypes. It's key that the ADCs were developed with the idea of sparing healthy cells from chemotherapy, but that doesn't happen yet. We still see chemotherapy-related side effects. We see neutropenia, which in some cases is fatal with SG. We see with TDXD nausea, alopecia, with Dato-DXD, we see stomatitis. We still see side effects with ADCs because still they carry chemotherapy, and some of that chemo does reach normal cells in the body. And so it's important to remember how to prophylax and how to monitor for these toxicities. For specifically ILD, mostly observed with TDXD and Dato-DXD, it's important to screen the patients, scanning frequency the chest, usually every 6 to 9 weeks, ideally, but also 12 weeks is reasonable, no more than that. Synergy, so having ourselves helped by a multidisciplinary panel, including radiologists and pulmonologists, can be helpful, especially for patients with symptomatic ILD. Stopping treatment with either TDXD or Dato-DXD if you have ILD, and using steroids, which are also the mainstay of treatment for interstitial lung disease. And then stomatitis. So we were used to stomatitis with everolimus. Now we see it with a new agent, with Dato-DXD. And similar to everolimus, there is this hope that prophylactic steroid-containing mouthwash can help. We are in the process of producing prospective data, but in the meantime, it is recommended that patients on Dato-DXD utilize prophylactic steroid-containing mouthwash, ideally 4 times daily, utilize good oral hygiene, and of course, we are meant to educate patients towards this side effect. And then cryotherapy, using ice chips or ice water during the infusion, is something that has been attempted to reduce the toxicity of this regimen. Ocular toxicity is also something that is emerging with some ADCs, such as Dato-DXD. So patients should receive an ophthalmic exam at baseline, ideally before starting or shortly after starting Dato-DXD. And then, of course, in case of ophthalmic problems and as clinically indicated, patients should avoid contact lenses and should utilize lubricant eye drops several times daily while on Dato-DXD. Nausea and vomiting remains, of course, prevalent across ADCs. Important to remember to use 3-drug regimen as prophylaxis. Cardiotoxicity mostly seen with TDXD. Important to remember it because patients can have drops in left ventricle ejection fraction. We need to monitor them during treatment, either with HER2-positive or HER2-low disease. It doesn't matter. Finally, biomarkers, because with all of these drugs that are becoming available, we really would want to understand which patient benefits the most from which drug. And this is why some biomarker analyses were conducted, for instance, in the TDXD trials, Destiny Breast 04, the first phase 1 trial, J101, but really immunohistochemical expression for HER2 kind of failed to predict which patient benefit the most from this agent, which is why there's many additional ways that have been studied to better quantify HER2. Some of these involve tissue analysis, molecular imaging, liquid biopsy, or of course, artificial intelligence. The word I think we will hear the most in the next few years. But if you look at some of the efforts we've been conducting at Dana-Farber, for instance, we try to look at utilizing several different biomarkers in tissue from patients that receive TDXT in the real world at Dana-Farber. But when we looked at it in patients with metastatic HER2-positive disease, among 41 patients that received TDXT, if they had a higher HER2 amplicon score, they seem to have a longer time to next treatment, about 1 year, compared to patients that had lower HER2 amplicon score. So HER2 detected with mRNA does seem to matter. And the same happens when you look at it with a very sensitive assay. This is called high sensitivity HER2, was developed originally at Yale, and looks at basically an immunofluorescence analysis that provides you with an attomole expression of HER2 in the tumor cells. And in this case, we also applied it in pre-TDXT tissue, and we found that the expression of HER2 in this tissue nicely predicted which patients would experience longer time on TDXT or shorter time on TDXT, which we are now hoping to expand to a larger data set. And finally, we also applied another proteomic assay, RPPA, that looks at HER2 expression, but also the payload target, topo1 expression. And we did see that both of them had a relevance to predict which patient benefit the most. So all of these is small data sets, is pilot trials. We recently published it on MPJ Precision Oncology. We are currently validating it, but I think it's kind of a food for thought about the fact that we do need biomarkers. And of course, AI will hopefully help in this setting to put together different features to predict outcomes with ADCs and beyond ADCs, because also oral SERDs and other targeted therapies will need biomarkers. Some of them already have biomarkers, some of them are in development. All right, I think after this marathon, once again, of data, it's probably time to put all of this together into some clinical cases. And I will need again the help of Dr. Kaliski and Leubel, first of all, to discuss the case of a patient that basically had ER-positive breast cancer. Dr. Kaliski, would you help us with that?
Absolutely. So this is the first case. She's 56 years old. She's postmenopausal. She's been diagnosed with right invasive ductal breast cancer. It's 95% in terms of the estrogen receptor expression. Progesterone receptors was 40% and was HER2 0. She was asymptomatic, had well-controlled hypertension. She was diagnosed with metastatic disease to the bone and with several pulmonary nodules and a family history in terms of her mom being diagnosed with breast cancer, but older age. So she did have a biopsy of a lytic lesion, which confirmed that it was strongly hormone receptor positive and HER2 negative. She did germline testing. This was negative. And she did undergo next generation sequencing, which did not identify any actionable mutations. So she started on ribociclib and letrozole and got bone-targeted therapy with denosumab. And on her systemic scans at 3 and 6 months, she had an excellent response. So I think, the questions are for us to discuss is, would you consider checking for ESR1 mutations? And maybe we'll pose this question of, would you consider this if this was an approach that was approved? But if it is, would one consider checking ESR1 mutations? And then the other question is, if you don't do that, what are the options if her tumor progresses?
Thank you, Kevin. These are great and tough questions, and I will ask the help of Sibyl to understand if Serena-6 is ready for prime time. So Sibyl, the million-dollar question, actually much more than $1 million, are we ready to start looking at ctDNA and in patients that have not progressed on first line, that are still on first line? And if so, would you do it like the trial did, like at every scan, or in some other scenario?
Well, I think we have not really enough information on if that really improves the overall survival in the end. And this is the ultimate goal. And therefore, we should, I mean, it's an intriguing concept just to look at ctDNA, but at this time point, it's more like a tumor marker, and we never did looking at tumor markers alone and then change the treatment based on tumor markers. So we need to be careful here. It's whether we are yet there to make really drastic changes in the overall therapy without knowing that we really will improve the overall survival. And we also know that it leaves the patient with some angst about what's really happening to me. Is this a massive progress? We don't know that yet, which organ is involved. And so I think we need to be careful, maybe careful, but we need to be mindful how we talk to the patients and how we really put that into practice then, because we need to keep in mind a patient running on a treatment which is fairly well tolerated and when we look at the curves, we also need to keep in mind that the patients have received one treatment less in the control arm. So I'm here to play the devil's advocate and to show that we need to look a little bit from behind the scenes and not only look at the separation of the PFS curves at the beginning.
Thank you. Totally agree. It's not an easy trial to interpret. It's very different from most of the other trials, and so it does require a bit of thought to be interpreted. I will say one piece that kind of convinced me, one pro of the approach, is basically the quality of life improvement. Of course, thinking that even if you don't prolong overall survival, at least patients can live better with less bone pain or other issues is at least something you gain. But of course, this comes at the cost of, first of all, financial costs of doing ctDNA every few months, every 3 to 4 months. And then, of course, potentially it could be detrimental on OS. We cannot fully exclude yet that starting a treatment earlier in the long run may just remove an additional treatment option. So many open questions, but there's so much more also that deserve discussion. And so another piece, you mentioned what are the therapy options if disease progresses. Gedatolisib may become available for a large population of patients without PIK3CA mutations. And of course, the data from the trial, Victoria 1, were striking. At the same time, that regimen also has challenges. It has toxicities, it has practical challenges, basically an oral agent plus an intramuscular agent plus an IV agent almost weekly. Kevin, do you feel there is a population of patients from which you'd utilize that regimen, or are you still thinking about this? What are your thoughts about this regimen?
Yeah, I mean, one, just to start out, I do think that the Avera regimen gets approval, and we'll see whether it's restricted to patients with ESR1 mutations or not. Given the exploratory analysis for the wild type, it really didn't seem to benefit in the same sort of way. And I do think that for those patients who have tumors that progress on CDK4/6 inhibition, and if it's approved in patients with ESR1 mutations only, I think that it will be a very good regimen that seems to be well tolerated. Your question about Victoria 1 is, I think the data are impressive. We see that with both doublet as well as triplet. And the data that we're seeing right now for patients who are PIK3CA wild type. So I'm really looking forward to seeing the data in patients who have PIK3CA mutations. However, I do think that the intravenous administration, 3 weeks on, 1 week off, can be restrictive, especially for patients who may have other oral options. And even if we're moving past endocrine-based treatments, we have other options that we may be considering, like capecitabine, which is another oral option for patients. And so ultimately, I think it's a good and active drug. I think that the time spent in the infusion center and also the discussion about the side effect profile, like stomatitis, et cetera, will be important to have with said patient. But just to reiterate the point, I think it's really the administration that will be a challenge.
Thank you, Kevin. Totally agree. So before moving to the next case, I have one last question for Sibyl. So we saw that basically the key words in your positive disease over the last year was combinations. But we also know that we have a single agent oral SERD approved. Actually, we have two. We have elacestrant and imlunestrant for patients with ESR1 mutations. Are there still patients for which you would think of an oral SERD monotherapy in the second line, Sibyl, or do you think we're going to gradually move toward combinations in this setting?
So in my opinion, I find it very difficult to give a patient in this early line a monoendocrine therapy. Personally, I think monoendocrine therapy is not the optimal treatment for a second line. And I think this should be a combination with a targeted agent if that is possible for toxicity reasons, if that is possible for the biology of the tumor, and if that is what the patient is willing to do. And I think we need to be quite open here. Personally, I'm a bit sad that we have not yet seen any combination data here for first and second line with the new SERDs. I think this is a better therapeutic option, but as monotherapy, not for the majority of the patients. We might have patients who have a lower performance status where we do not want to give two targeted agents. Maybe we don't want to give, we want to deal with the side effects and so on and so forth. These might be candidates for a monoendocrine treatment, but otherwise, I think we have moved on beyond monoendocrine therapy, especially in first and second line. In later line, I think this is another picture, is another chapter of the disease, and there we might have the patients might become a candidate again. Also for maintenance treatment, this is an option, but not for really treating the disease in second line and after a CDK4/6 inhibitor progression, where we know that the majority of patients really have an endocrine resistant disease.
Thank you, Sibyl. This makes a lot of sense. And I do hope that, having all of these new options available will allow us also to tailor treatment based on the clinical profile and also patient preferences. So in the future with more drugs, this will be easier to do. But let's jump into, probably we discussed already a lot of these questions. Let's jump to a different case. This is a case of a patient that is 44 years old, is a personal trainer in good performance status, no major comorbidities apart from panic attacks, infertility, no allergies, no family history, and no BRCA mutations. She is diagnosed with a screening mammogram, with a palpable node in the right breast that is about 4 per 2 centimeter and also has prominent right axillary lymph nodes. And upon biopsy, it turns out to be a grade 3 invasive ductal carcinoma that is triple negative, HER2 2+ FISH negative, and there is also carcinoma in the axilla. The body scans show no distant disease, and so it's a stage 2B triple negative breast cancer for which the current standard is, of course, the Keynote 522 regimen. She receives carboplatin, paclitaxel, pembro, followed by dose-dense AC pembro, completes this regimen, and unfortunately, she has residual disease, 1.2 per 1 centimeter, which is why she completes adjuvant pembro, but also adds capecitabine. This is all completed in December 2024, and shortly after, in December 2025, about 1 year later, because of a screen, let's say a surveillance scan done for the high risk of recurrence, she's found to have actually metastatic recurrence, both in the body, in the lymph nodes, in a kidney, and also a small 7 millimeter brain lesion. And a liver biopsy is performed. She has basically still metastatic triple negative disease that is HER2 0 now, and PD-L1 negative, no actionable mutations on NGS. So basically, first line PD-L1 negative, triple negative breast cancer with a small brain, 7 millimeter brain metastasis. And so one thing I will ask first to Kevin is, how do you approach this specifically regarding the brain metastasis? Do you think we need to ablate that brain metastasis with radiation, or do you feel confident with the treatments that we have to start a systemic treatment? And if so, which systemic treatment?
Mm-hmm. So a few thoughts. One, I will say, in terms of the local treatment, in clinic would tend to treat this with like stereotactic radiation, something of this sort. I mean, it's quite small and treatable. There are certainly studies that we have, including in HER2 positive disease, like for instance with tucatinib, where there are patients that have untreated that you can see response with agents that we know have good CNS activity, but so small, I think that I would likely treat it and then continue to monitor that area. I think based upon the data that you showed, we have compelling data to utilize a TROP2 ADC. We could talk about something like SG or Dato-DXd and talk about the side effects and how they are differently administered. As you had referenced, the response rate was a little bit higher in the Tropion study, though, of course, we should not be doing cross-trial comparisons, but it is one thing just to note. The only other thing that I would mention is also it seems like she had the PD-L1 expression was based upon her liver biopsy, and we do know that PD-L1 expression can be lower in the liver, so it might be if I had access to other tissue, also just check for PD-L1 expression.
That's such a great point. Many great points. And so I'll turn back to Sibyl. Sibyl, for a patient like this that doesn't have major comorbidities or contraindication to either of the TROP2 ADCs, what sways you toward choosing one over the other? The patient asks you, doctor, I will do whatever you tell me to do. Which agent would you pick between Dato-DXd and SG for this patient?
Well, I think this is very difficult to be answered, and currently, first of all, I would actually like to see the BRCA mutation status. Maybe I've missed that, but I think this is a very important piece of information I would like to see before starting any treatment here. And we have seen very nice data from the Destiny Breast 06, where we enrolled only a small number of triple negative patients. But here we saw that the ADC, the TDXD worked especially well in this very sensitive BRCA mutation carriers. But we also know that the PARP inhibitor would be a treatment of choice here. I think we need to bring that into consideration, since we are discussing not only one aspect of treatment, but we need to have a holistic view of what is possible. And I think this would also have been a treatment option for the post-neoadjuvant setting, since she had a non-PCR, just for our audience to see what you really need to ask for these young triple negative breast cancer patients. Never forget about the BRCA status. Now, coming back to your question, I think we haven't seen any head-to-head comparison between the two. I think they're mainly different. Both are TROP2 agents. They have a different payload. One is the DDXT payload, one is Angovitican. I think we really need to make it according to the side effects, and also about we talked about the IV regimen of gedatolisib, and here we have, of course, SG needs to be given in 2 weeks out of 3 weeks, whereas Dato is being given every 3 weeks. Side effect option, you mentioned a predominant non-hematologic toxicity with Dato-DXd, predominant hematologic toxicity with sacituzumab govitecan. So, and I think also in the combination, whether you need to re-challenge and PD-L1 and a checkpoint inhibitor, this is also, of course, a question in a patient where we still have a PD-L1, we might have a PD-L1 positive tumor. But otherwise, personally, I think we have seen more data, overall more data on SG, and usually I follow where we have seen the majority of data, because I think the majority of the data also plays an important role. We have seen slightly different data in the first line, but one trial really had a mandatory crossover, the other trial did not, so it makes it a little bit more difficult to interpret the data, although the response rate was higher with Dato compared to SG, but these cross-trial comparisons are not very helpful. So we need to put the side effects on the table, the schedule on the table, and then we need to discuss with the patients what are the treatment options. And you mentioned before the sequencing, we also need to discuss what sequencing options we might have with one or the other agent. And I think we should also discuss, is TDXD an option? If the patient is HER2 low, you have that already here. What would be then the best sequence for this patient? And ADC after ADC, if that is at all an option, we don't know yet. But this, I think, makes it for us in everyday clinical practice rather difficult to make the right decision, especially in a tumor conference where not everybody is really knowing the patient very well, and the treating physician might have another opinion than the rest of the people sitting at the tumor board. But I think these are the relevant options and discussion points we have, and we need to bring that in front of the patient as well. It's a shared decision making, also in metastatic breast cancer, especially when it comes to the toxicity, where we have 2 different ADCs or maybe 3 different ADCs, even with such a different toxicity profile.
I couldn't agree more. When you have more than one standard, that really becomes a shared decision making. For instance, this patient received the Keynote 522 regimen, and that really is much less of a shared decision making just because it's such a solid standard. But instead, here we have 3 different ADCs, each one's with pros and cons. So I do think that, as you mentioned, it's important really to understand deeply what the patient wants and prefers. But let's go for a burning question before moving to the HER2 positive section. Kevin, this patient ends up receiving a TROP2 ADC. Let's just make it up. She received sacituzumab govitecan, and she does well. But after 9 months, she has progression of disease in the liver, and not in the brain, just in the liver. But it's multifocal. There are many new metastases. You clearly need to change treatment. What treatment would you select at that point, assuming that and ctDNA profiling didn't show any more biopsies? Basically, what you have is 2 ADCs, although Dato-DXd is not yet approved, and of course, many chemotherapies. Do you have any pathway to decide in this case?
Yeah, I mean, for this particular patient, we would make sure that we're picking an agent that we know has some good CNS penetration, right? And I do think that the data that we have so far about ADC after ADC, which are really primarily institutional data, it does seem like that first ADC does better than the second ADC, just based upon the fact that the payloads are the same class, despite in case when we talk about TDXD compared to the TROP2 ADCs, of course, the antigen is different. But I think that we've also seen that, because one of the questions has also been, well, what about like direct ADC after the next ADC, as opposed to having some sort of sandwich approach where you have something in between? It didn't seem like it really makes that much of a difference. So my enthusiasm of ADC after ADCs not terribly high, though I feel like for a patient with triple negative breast cancer, ER hormone receptor negative, HER2 low, we are limited in terms of the number of options that we might have. And so I generally now tend to think about utilizing some chemotherapy next that has penetration to the CNS. Giving TDXD is not totally unreasonable, but it does give me pause just based upon the institutional series that we've seen.
This makes a lot of sense. Just a tiny follow-up question. This patient seemed that she had like 2+ disease in the primary tumor and HER2 0 in her metastasis, 0 ultra low. We know there is an approval in ultra low for hormone receptor positive disease, but the question is, would you apply that ultra low thing also for triple negative, or would the primary tumor be sufficient for you to consider TDXD in this case?
Well, I am happy to answer that question and then just highlight data that you've presented, right? You presented some data at San Antonio that suggested that the response that one has tends to be really dependent on what that last biopsy showed, right? And could one rationalize, oh, it's HER2 low, thinking about, though the data, as you said, are really an ER positive, trying to get TDXD? Sure. I think I would consider that in the context of when I run out of some other options.
Makes a lot of sense. All right, I think we discussed a lot of triple negative, and there's so many pending questions for HER2 positive, which we don't want to miss, especially because they're complex questions from which I will need your help. And I will start from Sibyl, the most obvious question. You presented to us 3 amazing practice-changing phase 3 trials, very different between each other, DB09, HER2 CLIMB-05, PATINA. How do we put them together? Like, first of all, and of course, the first question whenever you have a patient with metastatic HER2 positive breast cancer is, do I start with TDXD pertuzumab in all patients since there was a benefit, or are there selected patients from which Cleopatra still makes sense? How do you navigate this choice between TDXD pertuzumab and THP, Sibyl?
Well, in general, I think the majority of patients would qualify for TDXD plus P as first-line treatment option. Of course, we would like to see and answer the question, do we really need the pertuzumab on top of TDXD? I think this is the remaining burning question, and therefore we would like to want to see those data. Now we have an approval based on half of the trial, which is interesting. So we have not yet the whole picture, but currently and the majority of patients are at high risk because they all have received, at least here, a dual blockade as part of the neoadjuvant treatment. If they have just received a taxane and trastuzumab, you can consider them as a lower risk group and giving them just taxane plus HP. But if we look back to the patient population enrolled, only a tiny population had received T-DM1. I think it was less than 5% of the patients, and certainly not all of them had a PCR, and really only a fraction of the patients really received pertuzumab. So this is not really the patient population we see probably on this and that side of the Atlantic. But this is a global trial and affects the global treatment, and not all patients have the same access to the primary treatment. Therefore, I think for some of us, this makes it a little bit more difficult to interpret the data. But we had the same issue when the Cleopatra data came out, and not all patients in that trial were actually had received trastuzumab as part of the primary tumor. So for me, I tend to give the best treatment first, and I think this is clearly the best treatment with a hazard ratio of 0.56, and unless there are again toxicity reasons why I would not like to expose the patients to T-DXd. And I think also the treatment-free interval sort of plays into it. We had de novo patients, we had metastatic breast cancer patients in it. We looked at the difference by subgroup. There was no relative benefit change. We know that de novo patients tend to do a bit better. But for me, the longer the patient is out, the lower is the risk. And of course, the higher risk patients which relapse really very early and are fit for T-DXd plus P, I would give them T-DXd plus P. Of course, the other two trials, the HERCLIMB-05 and PATINA, they answer a completely different question. They answer, is a better maintenance treatment. And of course, when we had the Cleopatra regimen, we only could give 6 to 8 cycles of a taxane. We could not give the taxanes until disease progression. So eventually we had to stop the chemo, and then we automatically continued. Is that a real maintenance? Well, we can argue if that is maintenance treatment, but with the addition of either tucatinib for all or a CDK4/6 inhibitor plus endocrine treatment for the hormone receptor positive population is really a change in the concept in the maintenance treatment. And it shows that just continuing an HP is probably not enough. We have learned that. So we better to give something on top for the patients. Probably this is true for all lines of treatment. And one additional comment I would like to make, because there was so little time during the talk, the HER2CLIMB-05 trial did not use for all patients endocrine treatment for the hormone receptor positive population. About 50% received that, while it was mandatory or the basic concept in the PATINA study. But when we take out and look at the hazard ratio in the HER2CLIMB-05 for the hormone receptor positive and the PATINA study, it looked very similar. And so again, it comes back to the question of toxicity, treatment adherence, how often do we need to see the patients? We have a lot of experience with the CDK4/6 inhibitors already. We know exactly how to handle those patients. So I think it's a different paradigm. Do you believe in continuing, and we can do that with T-DXd plus P most probably as long as possible, or should we stop and change to a maintenance concept? This had not been investigated on the back of T-DXd plus P so far. Or do you start with HP and then switch to a maintenance concept? But we know that about 30% do not achieve a partial response. They might still have stable disease, but we also know that by line we lose about 10% of the patients. We do not make it to the next line. And at the moment, we don't know who are those patients who don't make it to the next line of therapy. So they would not have the chance to get T-DXd as second-line treatment.
That's so relevant, and especially because we know that we have this extremely active agent, T-DXd, and you really wouldn't want a patient with HER2 positive metastatic breast cancer not to receive this treatment that we know in the second line improves overall survival by almost 1 year. So it really becomes a question, as you mentioned, of trying to identify those patients that may not receive it later, that 10% of patients that may not receive it later. But in truth, it's also trying to prevent some progressions that may have an impact on the patient quality of life, including brain progressions. So being able to almost double PFS in the first line, for sure, it's very relevant, but it comes with side effects. We know that the HP maintenance phase of Cleopatra was extremely well tolerated, is extremely well tolerated by patients. TDXT can be extremely well tolerated, but it can also come with nausea, with fatigue, with interstitial lung disease in some patients, and there were even some fatal ILD cases in DB09 and most other trials. So the million-dollar question for Kevin is, do you stick to the DB09 regimen, treat with TDXDP to progression because that's what provides the longest PFS, or instead do you have in mind some threshold where you would think of dropping the TDXD and going to maintenance, or it really depends on the clinical scenario and patient preference? How do you feel about this?
Yeah, I mean, it does depend, but I will tell you, especially for the patients that are ER positive, one, I will say I do start with DB09 for my frontline patients. And then I have shifted to the patina regimen for our ER positive patients if patients are responding and doing well, like for this very concern that you're raising in terms of side effects, needing to get intravenous infusions, things like that. Though, of course, they're still coming back to get either an infusion or injection of their HER2 monoclonal antibody if they are switching to patina. I think that there are some circumstances where I would think that I would just continue DB09. Let's say you have a patient who presents with extensive brain metastasis or has extensive visceral disease, and you're hoping to really continue and get a response. Those are certainly circumstances that I would continue. I would also say that I may have some patients who have newly diagnosed HER2 positive disease. Let's say it's ER positive and it's very limited disease. And I do think that one of the questions is, do I really need to give something like an induction, or could I just do patina from the beginning, right? Like not even the maintenance, just start with endocrine-based treatments and a CDK and HER2 monoclonal antibodies. And so I think that there are lots of remaining questions. As we know, it's not a one-size-fits-all approach for everybody. And that's why it is a little bit patient-specific, because also some patients are willing to accept some things compared to others, and the amount of disease that patients have at the time of their newly metastatic diagnosis can be different.
That's so true. So once again, I think across subtypes, we have reached a point, thanks to 2025, which brought so much innovation, where really we can tailor treatment based on clinical profile, burden of disease, patient preferences. And this makes our job a bit more difficult because we don't have really strict algorithms where after A comes B and then C, but actually we need to discuss and figure out the best approach at every time point. But I think that's also the art and the beauty of medical oncology and why it's going to take a while before AI replaces us, hopefully. And so one last burning question. So Sibyl, one thing that has come up both in Cleopatra and DB09 is that patients with PIK3CA mutant HER2 positive metastatic breast cancer do worse. They remain for a shorter time on Cleopatra, but also on TDXD, pertuzumab. Does it mean that we have to look for PIK3CA? Do you think this provides enough reasoning to do a ctDNA at baseline? Or since we have no drugs approved to target that, you would not recommend that?
Well, I have personally, of course, a big interest in PI3 kinase inhibition, and I think it's relevant also for, in general, it's relevant for HER2 positive disease, but we have no treatment option for those patients. I think we should develop treatment options for those patients with the PI3 kinase mutations as they do generally worse. It is a sort of a resistance marker, but they benefit to the same extent from the treatment, although they have a worse prognosis. So it's a prognostic marker, but not a predictive marker for response to therapy. And we have seen that in Cleopatra, so HP is better than H alone. We have seen that in the DB09 study, TDM1 plus TDXD plus P is better than THP. also in in patients with a PR3 kinase mutation. Therefore, it's probably of academic interest to know the PR3 kinase inhibitor mutation status. It's of interest, but it has no clinical impact. And for the everyday clinical practice, I would not recommend to do that, because we should only do diagnostic procedures where we know those have an impact on the treatment decision making. Otherwise, we spend money which is not leading us anywhere. For an academic interest and for a research program, it's completely different, and we can do that.
That's a great point, and it's a question that we should address in a trial, ideally. There is a trial, maintenance trial with inavolisib that is ongoing, but still there is no answer if looking for this mutation, looking for genomics in HER2-positive breast cancer really helps, besides looking at HER2, and so much still to work on. This is just a perfect way to close this, basically reminding everybody that conversation with the patient is key, especially when you have, like in this case, multiple options, reminding about not only the present, but also the future. You don't want to delay too much the use of an agent that actually is active and could extend the patient overall survival, but also remembering quality of life is always important. So this thing is getting so complicated, breast medical oncology, but also so exciting. I think this program also prepares us for 2026. So many things coming our way: ESMO Breast, ASCO, ESMO. So stay tuned. I stopped torturing my co-faculty. Thank you so much, Dr. Kalinski and Leubel, for addressing the many difficult questions we ask in this program. And thank you to the Medscape team for coordinating all this. And thank you to the audience, of course, for listening to us. Wish everybody a wonderful day, afternoon, evening, and see you in Berlin or at Chicago at the next conferences. Thank you.
Thank you. Bye-bye.